Imagine a critical medical emergency where the most crucial diagnostic clue just disappears precisely when the patient starts feeling better. Or maybe a sudden life-threatening heart condition triggered not by stress but by overwhelming joy. Sounds like something straight out of a medical thriller, right?
Absolutely. But these aren't fiction.
These aren't just dramatic plot devices. They're real, often subtle ECG syndromes that can be incredibly tricky to spot. What if understanding these rare, sometimes hidden electrical patterns could literally be the difference between life and death for someone you care about? Today, we're diving deep into the fascinating and, yes, sometimes pretty frightening world of unusual heart syndromes that leave their unique signatures on an electrocardiogram. Welcome to the Deep Dive, where we take your source material and basically extract the most vital nuggets of knowledge, helping you become truly well-informed without all the information overload. Our mission today is to explore a spectrum of less common, yet profoundly significant electrocardiogram syndromes. These are the kind of medical mysteries that, challenge even seasoned clinicians.
Exactly. We'll be uncovering how these syndromes manifest clinically, what unique patterns they etch onto an ECG, and crucially, why recognizing them quickly is absolutely vital for patient outcomes. It's really about learning to spot the whispers of the heart before they become a scream for help.
Right. And we've got a fantastic review article from the Journal of Personalized Medicine guiding us today, laying out these diagnostic puzzles and, thankfully, their solutions. Now, before we jump right in, a special thank you to London Heartbeat's Z Academy UK for their invaluable educational support on this deep dive. They offer over 150 popular courses designed to really broaden your knowledge. So if you're as curious as we are about understanding these complex topics in a clear, concise way, you'll definitely want to explore their offerings. Make sure to subscribe to their social media channels. That's Facebook, Instagram, and YouTube for free. Regular updates so you don't miss future amazing discussions like this one. And for those who want to go even deeper, you might consider their higher-level YouTube membership. You get early access to educational videos and even personal chats and guidance sessions. Okay, so we'll walk you through each of these syndromes, from their intriguing discovery to their specific ECG patterns, the signs patients might experience, and how these conditions are treated. Get ready for some serious aha moments that will probably reshape how you think about heart health.
Quiet for 2 seconds. Deep dive. Part 1, syndromes of ischemia and stress. Let's kick things off with Wellen's syndrome. This was first described back in 1982 in the Netherlands. What makes this one so incredibly unique, and why is it sometimes dramatically called the widowmaker?
Well, it's a truly critical pre-infarction state. That means it's a severe warning sign that a massive heart attack is imminent, often involving a key artery called the LAD. What's truly counterintuitive and makes it so dangerous is that the classic telltale ECG changes appear when the patient is pain-free.
Wait, when they're pain-free?
Exactly. They might have had chest pain earlier, but when they feel better, that's when the critical diagnostic clue shows up on the ECG. If this pattern is missed and the patient is only given medical treatment without, immediate intervention, a significant number of them, historically maybe up to 18% in the initial studies, rapidly progress to a massive myocardial infarction.
Wow.
That's why it's earned that ominous nickname. It signals a potentially fatal blockage if you don't act really quickly.
So how does this disappearing clue actually work? What's going on inside the body that makes the ECG look normal during pain and then abnormal after the pain subsides? That seems completely backwards.
It is, and it's a fascinating physiological dance. Typically, it starts with an athermatic plaque that's a fatty deposit rupturing inside a coronary artery. This rupture forms a tiny clot, an embolus, that temporarily blocks the left anterior descending, or LAD, artery. This temporary blockage causes the chest pain you might expect. But here's the key. The clot often isn't stable. It might spontaneously dissolve or break down before a full, irreversible heart attack occurs. It's during this phase, when the blockage temporarily resolves and blood flow is restored to the heart muscle, a process called reperfusion, that the stunned heart muscle begins to show those unique ECG changes.
Oh, okay.
It's like the heart is temporarily recovering, but in its recovery, it's screaming a warning that it was just moments away from a total shutdown.
What would a patient experiencing Wellen syndrome typically feel? What are the common symptoms that might bring them to a doctor, even if the ECG clues only show up later?
They usually present with what we call unstable angina. This is a type of chest pain felt behind the breastbone, often radiating to familiar areas like the left arm, jaw, or back. Sometimes described as crushing or tight. It can be triggered or worsened by exertion, cold exposure, or even heavy meals. These episodes typically last around, say, 15 to 25 minutes. Patients might also experience shortness of breath, excessive sweating, dizziness, or palpitations. What's really crucial for clinicians, though, is that sometimes a presentation can be completely atypical.
Atypical. Like how?
Well, there have been reported cases where a patient had fainting spells, intense abdominal pain, and vomiting, with absolutely no chest pain at all. This really highlights why doctors need to be vigilant and consider Wellens even with unusual symptoms.
All right, let's get into the specifics for the ECG. This is where the detective work really begins. What exactly are we looking for on the electrocardiogram to spot Wellens? Give us the signature signs.
The golden rule here is serial ECGs. You absolutely cannot rely on just one. While the ECG might look completely normal during the actual chest pain episode, the critical telltale signs appear when the patient is completely pain-free. We're looking for very specific T-wave changes in leads V2 through V3, sometimes extending to V4. There are two types. Type A Wellens shows deeply inverted and symmetrical T-waves, think of them like deep, narrow valleys on the ECG. Type B Wellens presents as biphasic T-waves, meaning they go up and then immediately down, like a small hill followed by a valley.
Okay.
These often start biphasic and then evolve into the deeply inverted type A. What's also key is that cardiac enzymes, like troponins, might be normal or only slightly elevated, which can be misleading if you're expecting a full-blown heart attack. Coronary angiography, a definitive test, almost always reveals a critical obstruction in that LAD artery and a critical warning. Cardiac stress testing is strictly contraindicated.
Really? Why?
Because putting stress on the heart in this state could trigger a massive myocardial infarction right there on the treadmill. It's too risky.
Got it. To really distill this, what are the absolute must-haves for a Wellens diagnosis? What's the definitive checklist?
Okay, for a definitive diagnosis of Wellen syndrome, you need a combination of clinical context and ECG findings. First, a history of angina, especially that unstable angina. Second, cardiac enzymes that are normal or only mildly elevated, not showing a full heart attack. Third, the characteristic T-wave abnormalities we just discussed, specifically in leads V2, V3, appearing when the patient is pain-free. Fourth, the absence of pathological Q waves, which would signal a completed heart attack. And finally, no significant loss of R-wave height, again, differentiating it from an established infarction. When you see these elements together, it should, ring major alarm bells.
What could Wellens syndrome be confused with? I imagine those T-wave changes could look like other things. And what's the treatment path once it's correctly identified?
Well, yeah, many conditions can cause T-wave inversions, making the differential diagnosis a real challenge. Things like Takotsubo cardiomyopathy, which we'll discuss later, or even something as simple as low potassium levels can cause T-wave changes. A pulmonary embolism, or even the heart's memory from previous electrical events, can also produce T-wave inversions. That's why the specific location, V2, day 3, and that crucial context of the patient being pain-free are absolutely vital. The prognosis is, unfortunately, quite poor if Wellen syndrome goes unrecognized and is only treated with medication, often because it's mistaken for a less severe form of acute coronary syndrome like NSTEMI.
But if they catch it?
However, with prompt coronary revascularization, meaning opening up that blocked LAD artery, either through percutaneous coronary intervention, PCI, with a balloon and stent, or coronary artery bypass grafting, CABG, the prognosis is remarkably good. And of course, identifying and managing underlying risk factors like high cholesterol is also crucial to prevent it from happening again.
Okay, let's bring this to life with a story. Imagine you have a friend, Sarah. She's a fit 45-year-old, usually runs marathons. Lately, though, she's had some weird chest tightness after her morning run, but it always eases up by the time she gets to work. This past weekend, she had a particularly bad episode of crushing chest pain that sent her to the ER. But here's the twist. By the time the doctor saw her an hour later, the pain was completely gone. Her initial ECG was normal, and cardiac enzymes were just borderline. The doctor, almost ready to discharge her, noticed something subtle on a repeat ECG taken an hour later when Sarah felt fine. In leads V2 and V3, those T waves were now deeply inverted, just like you described. That seemingly normal pain-free period was the critical clue for Wellen syndrome.
Exactly.
It led to an immediate angiogram which shows severe LAD blockage. This quick recognition, driven by knowing Wellen's pattern, saved her from a massive heart attack later that day. It's a powerful reminder of how critical these subtle ECG shifts can be.
Absolutely powerful example.
An understanding of these syndromes are truly critical for early detection, appropriate treatment, and ultimately preventing fatal arrhythmias and sudden cardiac death. The potential for misdiagnosis and dangerous treatment delays is very real when these conditions aren't recognized. Each pattern tells a critical story that healthcare professionals must be prepared to read, potentially transforming dire situations and quite literally saving lives.
If you could distill our deep dive into a few top essential takeaways, what would they be?
Okay, first, the ECG is not always straightforward. Crucial diagnostic clues, like in Wellen syndrome, can appear when symptoms are absent. That counterintuitive presentation is vital. Second, the heart can react physically to intense emotional or allergic stressors, as we saw in Takotsubo and Kunis syndromes, showing a profound mind-body or immune cardiac connection.
Right.
Third, not all serious heart conditions are caused by blocked arteries. Some are purely electrical or genetic, like Brugada or Lepard, shifting focus from plumbing to wiring. And finally, some athletes face unique cardiac risks, like Papillama syndrome, due to strenuous training, emphasizing that fit doesn't always mean no heart risk. It highlights the importance of personalized approaches.
To leave you with something to ponder, considering the intricate and often subtle signs of these syndromes, what other seemingly normal physiological responses might be masking critical underlying health issues that we are yet to fully understand? Makes you wonder how many more hidden messages our bodies are trying to send us. Quiet for 2 seconds. Multiple choice questions. MCQs. All right, it's time to test your newfound knowledge with some quick questions based on our deep dive. Don't worry, we'll give you the answers and a quick explanation. Ready? Number 1. Which ECG syndrome is characterized by T-wave changes in V2, V3 when the patient is pain-free, indicating a critical LAD artery stenosis? A. De Winter syndrome, B. Takotsubo syndrome, C. Wellen syndrome, or D. Brugada syndrome?
The answer is C, Wellen syndrome. This one's unique because its classic T-wave changes in V2, V3 appear when the patient feels fine, signaling that intending LAD blockage.
Okay, number 2. In De Winter syndrome, what is a key ECG finding in precordial leads that differentiates it from a typical STEMI? ST segment elevation greater than 2 millimeters, B. Deep Q waves, C. Absence of ST segment elevation with upsloping ST segment depression at J point and peak T waves, or D. Prolonged PR interval.
That would be C. Absence of ST segment elevation with upsloping ST segment depression at J point and peaked T waves. Even though it's a STEMI equivalent, De Winter typically lacks that ST elevation, showing specific depression and peaked T waves instead.
Number 3. Kunis syndrome is defined by the simultaneous occurrence of acute coronary syndrome, ACS, and what type of reaction? A. A viral infection, B. A systemic allergic reaction, C. A cerebrovascular accident, or D. Renal failure.
The answer is B, a systemic allergic reaction.
Yeah.
Kunis syndrome is that combination of ACS with an allergic or hypersensitivity reaction involving mast cell activation.
Question 4. What emotional or physical trigger is commonly associated with Takotsubo broken heart syndrome? A. Extreme physical exertion only, B. Chronic inflammation, C. Heartbreaking events or intense stress, emotional or physical, or D. High cholesterol diet.
It's C, heartbreaking events or intense stress, emotional or physical. Takotsubo is strongly linked to sudden, severe emotional or physical stressors causing that catecholamine surge.
Number 5. Yamaguchi syndrome is a specific type of hypertrophic cardiomyopathy, primarily affecting which part of the heart, often resulting in a distinctive ace of spades appearance on imaging? A. The right ventricle, B. The left ventricular apex, C. The left atrium, or D. The interventricular septum.
The distinctive shape points to B, the left ventricular apex. Yamaguchi syndrome specifically involves hypertrophy of the LV apex.
Okay, number 6. Which of the following is a classic ECG triad for Wolff-Parkinson-White WPW syndrome? Short PR interval, normal QRS, absent delta wave. B. Long PR interval, wide QRS, inverted T wave. C. Short PR interval, wide QRS, presence of a delta wave. Or D. Normal PR interval, wide QRS, ST segment elevation.
The classic triad is C. Short PR interval, wide QRS, presence of a delta wave. This shows the accessory pathway bypassing the AV node.
Number 7. Lone-Gannon-Levine LGL syndrome is distinguished from WPW syndrome by the absence of what ECG feature, despite having a short PR interval, A. Q waves, B. T wave inversions, C. Delta wave, or D. ST segment depression.
The key differentiator is C, delta wave. LGL has a short PR but a normal QRS, and crucially, no delta wave.
Question 8. The diagnostic type 1 ECG pattern for Brugada syndrome involves what specific finding in the right precordial leads, V1, V3? A. ST segment depression greater than 1 millimeter, B. Coved ST segment elevations greater than 2 millimeter, followed by an inverted T wave, C. Prolonged QT interval, or D. Flat T waves.
The diagnostic pattern is B, coved ST segment elevations greater than 2 millimeters, followed by an inverted T wave. That specific cove-type elevation is the hallmark for type 1 Brugada.
Number 9. Friedreich syndrome is the simultaneous occurrence of atrial fibrillation or atrial flutter and what other major cardiac event? A, myocardial infarction, B, complete heart block, C, ventricular tachycardia, or D, supraventricular tachycardia.
Frederick's is the combination of AFib or flutter with B, complete heart block, third-degree AV block.
And finally, number 10. Papilloma syndrome, affecting young and middle-aged athletes, is characterized by recurrent episodes of what arrhythmia, often linked to strenuous long-term training. A, ventricular fibrillation, B, atrial flutter, C, paroxysmal atrial fibrillation, or D, sinus tachycardia.
That athlete-specific syndrome is characterized by C, paroxysmal atrial fibrillation linked to that long-term training and cardiac remodeling. Outro.
And that wraps up another truly illuminating deep dive. We hope you've gained a clearer understanding of these fascinating and sometimes hidden heart conditions that remind us how incredibly complex and resilient the human body truly is.
Understanding this broad spectrum of ECG syndromes is really a testament to the power of medical observation and the ongoing quest for precise diagnosis. Each unique pattern tells a critical story that healthcare professionals must be prepared to read to help ensure the best possible patient outcomes.
We're always learning, and we love sharing that journey with you. Until our next deep dive, stay curious, stay informed, and keep exploring.